Move on to the next live transmission. That is from Max Hospital, Delhi, by Dr. Balbir Singh, and one more from Promed Hospital, Chennai. Operator is Dr. Arun Kalyan Sundaram. This case expert panel members are Dr. P.C. Rath, Dr. Mohanty, Dr. Selvamani, Dr. V.T. Shah. I would also request Dr. YVC Reddy and Shailendra Singh and Vijay Kumar Reddy to continue as a expert panel members. Dr. Keshavmurthy joined.
Yes, sir. Good morning. Good morning, Dr. Sridhar Kasturi. Thank you.
Session.
Yeah.
Welcome, sir. You can moderate this session. You can take over, sir.
Good morning, everyone, and thanks to Dr. Sridhar Kasturi and team for organizing such a wonderful event where a lot of learning process is going on. And I welcome my expert panelists, Dr. P. Sirat, Dr. Mohanty, and Dr. Selvamani, to take part actively in the discussion of this case. The team at Max Hospital is ready, and I think we'll go ahead and start with the case. Dr. Balbir, good morning to you all and to your entire team.
Happy to see you.
Good morning. Can you see me and hear me?
Yeah.
Okay. Thank you, Dr. Sridhar. And we have great morning cases, and this is one of them. And I will need inputs from all of you.
Okay. Mute me then. Okay.
And I will need inputs from all of you.
The mic shouldn't be on.
I have with me my colleague, Dr. Brijesh, and our fellow, Dr. Sharil. And we will be showing a case which looks quite challenging from multiple aspects. And I will request Dr. Sharil to present the case first, and then we go further with it. Yes, Dr. Sharil. So, isko mic nahi laga. Okay, I will be showing this case on her behalf. So, next slide. So, this is a 61-year-old diabetic male gentleman, had unstable angina in 2016, where a mild left main and a triple vessel disease was noted. The right was not too tight at that time, and he was suggested, next slide please. He was suggested for a CABG with a syntax score of 40, and he was not willing for the same. And PTCA to LED was performed during that admission, and the rest was left on medical therapy. And actually he did very well. 2 years after the procedure, he had angina again, recurrent angina, including rest angina. And this time there was noted to have stenosis just proximal to the stent and increasing disease in the left main. So again, a surgery was suggested, and he took 3 grafts, Lima to LED, SVG to diagonal, and RCA. Next, please. In 2018, he had hematemesis and was diagnosed to have non-cirrhotic chronic liver disease, cirrhotic liver disease, non-alcoholic, so NASH-related CLD. He was child A classification. Upper GI endoscopy revealed varices, which were ligated. He was asymptomatic for 2 years, and this year he presented again with angina. And again, rest angina, multiple episodes, was on full medical management. On 18th March, he had melena and drop in hemoglobin. Repeat endoscopy showed scarring in the varices, but there was some red color and portal hypertensive gastroduodenopathy. Colonoscopy relieved angiomas, which underwent an argon plasma coagulation. Next. So now he had angina at rest, and after his stabilizing his melena, he underwent a repeat angiogram, which I'm going to show you. And can I show the angio? So I'm going to show you the previous angio. Do you see the angiogram?
Yeah.
Yeah, we can see it. Yeah.
Okay, so this is the left injection, which shows a left main artery stenosis, a tight proximal LED, and a patent stent, calcific lesion, long stenosis in circumflex, very small OM that takes off thereafter. Next, please. This is the cranial view, clearly showing a long LED lesion, pretty tight, and a left main lesion. Next. Similar in an RF cranial projection.
We are not able to see the angios.
Running
Subsequent.
movie is it, sir? Sir, show the running movie.
ये दिखाना यार, वो नहीं दिखाना. वो
And now
ये
movie.
Yeah, yeah.
ये नहीं दिखाना, ये दिखाना. एंजियो दिखाना. नहीं दिख रहा उनको.
Yeah, we can see it now. You have to move to the next.
You know, unfortunately, we are seeing what I have done. This is a guiding catheter shot. I want to show you the angiogram. So they're just trying to fix. So this is the left system, which we did today. Can you go to the next view? So you can see the cranial view with a long LED lesion. So I'm going to show you that on his complete angiogram, the lima was atretic. So lima was not flowing at all. He had a graft 2 RCA, which was very, very distal, and there was hardly any flow to that. The graft 2 OM had knocked off. So we are basically dealing with native triple vessel disease. We have RCA to tackle. This is the left system that I'm showing you. The RCA also has a 70 to 80% mid lesion, which we are going to reassess. This is what I have now. So the issues here are, can you go back to the previous view? So the issues here are multiple. Issue number 1, he is a high bleeding risk, as we know. On 18th March, he had melena and has been evaluated. He was admitted here 4 days back. And that time we got a capsule endoscopy, which showed no bleeding ulcers in the small intestine, even though there were small erosions noted on that capsule endoscopy. In consultation with the hepatologist and the gastroenterologist, they cleared him for antiplatelet therapy. Last 3 days, we have been giving him aspirin and clopidogrel. There has been no bleeding. And today's plan is to handle this LAD and RCA. And the second challenging point in this case is left main and LAD disparity in size. So if I look visually, the LAD would be about 2.7 and the left main proximal is at least 4.5. So we have a huge disparity. That's the next thing. And the third thing is a circumflex, which we have to save. So these are the 3 issues as we go in this lesion. And fourth issue is the calcium. So calcium, there is fluoroscopically calcium, but we'll image it because this is a post-op CABG, chronic disease, diabetic patient. How much calcium and how much debulking, or we can go ahead with NC balloons, is the next issue that is going to be decided. This picture shows calcium on one side of the vessel, which is the top side, and but reasonable calcium to be seen fluoroscopically. Now, we would like your views. I have wired both the LAD and circumflex. Next, please. So we wired the LAD first, next, and then the circumflex, next. Now, issue was whether we image. So we are going to image with OCT, whether we image without pre-dilatation or pre-dilatation. So as I will show you that we've taken a 2 millimeter balloon. We take this 2 millimeter balloon down. It goes quite easily. But when we inject contrast, as you will see now, there is no filling on the distal vessel. So if you have lesion that kind and you put an OCT catheter, you don't get good images. So it is always a good idea to dilate with a small balloon because it gives you a lot of things. It opens up the vessel, the diameters can change, the visualization is better. So rather than trying a native stenosed vessel doing an OCT may not be a great idea. So the other thing that it gave me, next please. The next idea that it gave me was that I could inflate this balloon. This is 6 atmospheres. There doesn't seem to be a residual waste, but we are going to do imaging now. And I will have your opinion of the panel before we go ahead with this case.
Yeah, Dr. Balbir, just for the discussion's sake, this patient is a very complex post-PCI, post-CABG, and obviously a vasculopath. And also that bleeding element which has come in sort of complicates matters quite significantly. So would you have liked to sort of stage him and pull him away from that bleeding event for a couple of weeks, or the indications were very compelling to take him on table for such a complex procedure with multiple stents and imaging and anticoagulation and whatnot?
Right. So he's had multiple episodes of angina. Every night he has had pain. And actually, when he was admitted, he was crying, "Do something or I will die." This was the situation when we admitted him. Actually, he was not even willing to wait for a day because he said, I've spent the whole night taking sorbitrates and not getting the relief.
Right. So there is a compelling indication. So
What was his hemoglobin?
Get him away.
Hemoglobin was 12.
12.
What about his EGFR?
So creatinine is 0.6. So EGFR is normal.
Okay, okay, good. And was the bleeding melena on antiplatelet, or he was not taking antiplatelet and he got bleeding?
So he was taking ecosprin when he got bleeding. He was not on dual antiplatelet at that point in time. But the gastroenterologists were sufficiently confident that they have fixed it, and they have done a repeat capsule endoscopy. They did a repeat upper GI endoscopy and said that it's clear. And 72 hours, we loaded him with the clopidogrel, and there was no fresh bleeding, no stool, no melena, and that's how we decided to go ahead.
Yeah. And no blood transfusion given?
No. He was given at the first stage two blood transfusion.
Okay.
Yeah.
So anyway, have you finished the OCT?
No, I'm going to start now.
You have chosen radial. Any particular reason or standard of care for you?
No, most of the time, 90% of the time, we do radial. Second thing is that the bleeding is much lower. So in a patient whom you have already so many issues of a non-cirrhotic disease, child classification A, where you know there's been GI bleeding, there could be a bleed into the groin also. So this is the best approach to go ahead with. And I have no doubts that radial is very comfortable in such a situation.
So this is 7 French.
Yeah, 7 French, 3.5 guiding catheter.
Slender.
Slender sheath.
What was his PT and INR?
Normal, 1.1. So can you see the
strategy you chose, Balbir?
So aspirin clopidogrel. So we loaded it with clopidogrel 2 days back and continued 75 BD for 3 days. So can you see the OCT screen on this thing? So I'm in the distal stent at the moment, and we'll take a pull back right here. Start. So we have
Excellent run, Balbir.
Yeah, so we will now show you. So
this is with contrast.
50% contrast.
Okay. What about his LV function? How is it?
Normal.
Good. Excellent. So at least something in favor.
Yeah.
EGFR and LV function in favor.
Yeah. So we'll give you the measurements now. So I will start from the stent. Here we have the stent, and you see the neointima, but the lumen area is 2.4, and it is 1.99 here and 2.1. So this part of the stent, the proximal part, does have disease, and this is you can see the angio dot coming. So we have an angio core registration. So this part is 2.5. There's a branch coming. And now you see the calcium. So the thickness of the calcium I will show you. So significantly thick sleeves of calcium where we saw the fluoroscopy. See this calcium here. And now we go forwards. The calcium on the 6 to 9 o'clock. And this is a fibrotic lesion here. Then some calcium here, tight stenosis. Now I'm approaching the left main. You see the left main. And if we take this as the normal part of the left main, the diameter is pretty huge. 3 point, this is about 4. And in the other dimension, it is 4.6. So I think we'll be okay with a 4 millimeter balloon. This is what it is now. This is the calcium here. Now I would take suggestions from the panel as to what strategy they would think. They would like to use an NC balloon. So I know that I have to go right here to the stent. So I will cover with 2 stents definitely. So what should be the strategy now?
A lot of calciums are there.
Yeah.
I think NC balloon is a good suggestion. And after that, you have I think a lot of calciums are all around LAD. I think you have to use some device to modify the calcium. I think the vessel size will be around 2.5, isn't it? LAD?
Yes, I'll check you the vessel size.
I think whether
So,
the
2.8.
IVL will be a good option.
So 2.83. So not a bad vessel.
Lot of plaque burden, so a good bed preparation is a must, I think.
Right. So we have, I agree with the discussion, and we've already chosen to go for an IVL. So I'm going to choose a 2.5 IVL, go all along the vessel. This vessel is quite big here, but even if we do a 2.5 here, rather than taking another balloon, it will be adequate. So I will go all along this vessel from the proximal end of this stent to this end with a IVL 2.5 millimeter balloon. Is that okay? Would you agree, or would you think some other strategy could be better?
Put multiple IVL balloon inflation in different areas of LAD. We prepare the bed. The stent.
Right. So I'm going to do that. So we're taking a 2.5 IVL balloon.
So for optimal using of the IVL, proximally just, I think we can have some area where we cannot use it because that area has.
Right. So let me see how I utilize these pulses properly.
Correct. And how much is the length? Because 12 multiplied by the length.
Length thickness.
You have to divide the length by.
So length is about 42 millimeter.
No, I'm saying the length where you are going to use the IVL.
Length, we're going to start from the tightest portion and see how it goes. We know there's calcium in 2 places, which is quite significant. The tightest point, so I'm going to start there, and the proximal end or near the ostium. These are the 2 points where the calcium is most significant.
Correct. Yeah. So I think we can optimally use that. The ISR in the stent doesn't have calcium.
Yes, right.
So it should focus on those calcified areas, and rest we can address with a cutting balloon or something.
Correct, because we do not know how much pulses the distal part will take and the proximal part will take.
Correct.
So that's one advantage of OCT. You see calcium on the angio, difficult to localize, but OCT can tell us exactly how optimally to use that IVL balloon. The problem is we have only one 12 millimeter length and 80 pulses.
Right. So, Dr. Shah, so if I look at the proximal, can you go back to OCT? If I look at the proximal part of the stent, we will show you that it is not fully expanded. This part of the stent, can you go further down?
Right, but we can use NC balloon there. There is no calcium there.
No, but we don't know the calcium. Once the stent is there with neointima, you will not be able to pick up calcium that well. And there is no harm in giving one pulse here so that I can get a better expansion when I go with the NC balloon on this part of the stent.
Okay, let's see. It's a good idea also.
Balbir sir, is it your routine criteria?
Dr. Balbir, can I put a question?
Yeah, please.
Yeah, Dr. Mohanty here. Good morning.
So, hi, Dr. Mohanty.
Yeah. So can it be other way? We take a scoring balloon or a cutting balloon or a Wolverine and try first and If it is
Yeah.
not working, then you can take IVL.
Not a bad idea. I had kept that in mind, but we had already spoken to the family that you may need an IVL. So I think if
But
I
the
have to choose,
calcium arc is not 360-degree, where there are two
but the thickness,
different quadrant of calcium.
yes,
Stent expansion may not be a problem here.
yes, right. But if we look at two things,
Yeah.
I'm tempted towards IVL on two counts. That we know that that this person has high bleeding risk. We know
Yeah.
we are optimizing our treatment to the best, that even if I have to stop clopidogrel at 1 month or maybe stop aspirin at 1 month, I should be safe, which can only happen if my stent expansion is excellent. So my best bet to get the best stent expansion is IVL, and cutting balloon could have helped if I had thought that I will not have to stop aspirin or clopidogrel sometime in his course, which may be very soon also. So with that in mind, we should take the best bet, expand this stent to the maximum that we can do. So OCT and IVL is going to be very key in getting a very good result.
That's true, but if the calcium load is too much, then it's if on a fibrous tissue, I don't know what will IVL will do if it is a major fibrous thing.
Okay, go up 4.
No, and the other thing is, Balbir, this is already a post-CABG patient, so you don't have that option.
Right.
Yeah, Balbir, Dr. Selvamani here.
Yeah, right, Selvamani.
What do you think is your role of IVL in eccentric calcium like this? So calciums are there here and there, and probably certain areas it is thicker.
Right,
so, but do you think it has a good effect there, IVL?
So the best bet for eccentric calcium is IVL or a cutting balloon. Rota may just miss that eccentricity of the calcium. So if we have best bet for eccentric calcium and calcified nodule at the present moment, till we get an orbital atherectomy, is IVL or a cutting balloon.
It will be interesting to see the post IVL run with OCT.
Okay, down, negative. थोड़ी देर negative. 4.
Keshav Murthy sir, we also have Promed ready from Chennai in case if you want to switch and come back. You're on mute, sir.
Down. 6 speaker now.
Right, we can do that while they finish this runs of EVL, and then we can come back and see the OCT again or what he has done. Because he has quite some significant work to do with the plaque, with cutting balloons or NC balloons. And while he's preparing the bed, we can just switch there and come back.
So I think, is it okay, Dr. Balbir?
Yeah, that's fine.
Yeah. Thank you.
Good morning, Dr. Vitisha.
Yeah, good morning, sir.
How are you, sir?
Fine, sir.
Good morning, Mohanty. Thank you for joining.
I didn't get the Zoom link. That's why I'm late.
Yeah,
no problem.
I told
no
Ravi
problem, Dr. Mohanty. We can always compensate for that.
Okay, no problem.
So we are
Arun.
Welcome, Arun.
Hi.
Very nice to see you in action.
Yeah. I wish I could. Good to see you guys.
Promed. Yeah.
How is everyone? Good?
All are fine.
Yeah, all good here.
All right.
Can you describe your case, or somebody can present the case?
Sure. You wanna? Oh, you don't have. I guess I'm the only one on the mic. So basically, surgical refusal. 72-year-old man with 3-vessel disease, angina, pretty refractory to medical therapy. So that's kind of the thing. Can we show the angiograms, please? Yesterday's, please. Is there a way to? Yeah.
So
I mean,
can
that's
somebody shift the screen? I think it's blocking half of your screen.
Arun,
Guys,
move the screen
the monitor.
bit,
Shift the monitor.
Move the monitor. Yeah. Good.
Yeah. Yes. Please go ahead. Still
further down. Camera boss, you got to tell me that. Okay. So yeah, can we show the diagnostics, please? That's all right. Yeah, just show. No, show from the beginning. Yeah. All right. So guys, I'm not sure if we can show you the external angiogram, like the outside angiogram, but that's kind of what we're dealing with. Yeah. So just go on. Just show the next picture, please. Show them a cranial. Show them something. Yeah. Play it. Yeah. So guys, unfortunately, then we got into action. So that's kind of what you're dealing with. Diffusely diseased circ, couple of tiny OMs. There's one diagonal that's probably large. Distal left main, LAD disease. Look pretty calcified, to be honest with you. That's kind of what we're dealing with. All right. So, and then there's a RCA CTO, just to make things interesting. So how do you approach it? And EF is pretty much preserved. I mean, it's like 50-55, I think. So all territories are viable. You guys want to, I mean, we kind of actually did the left side yesterday, just because we wanted to show you. I mean, this was supposed to be an OCT symposium, so I was trying to show you guys OCT, but I got a CTO and other stuff. So I'm not as, how to say this? I don't have the luxury of choosing a lot of, between a lot of cases. I do what I get. So yeah, go back. So we could talk about multiple things. I mean, this was all done already, so I can show you the final result. Go. So yeah, just go to the last one. So there's a lot of adrenaline and a lot of fun action. So we got this done yesterday. So that's your left main LAD stented pretty much to the ostium of the left main. We show them the caudal projection too, please. Thanks. Yeah, that one. All right, play it. So we kind of, I mean, just in case people are curious, we did a tap. It was I was the LAD into left main, and then I got done. So that was all last night, and then this morning we decided to go to the setup shots from today. First shot, please. First one. Forward. Yep. Okay. So the challenge in this RCA CTO is that it's an ambiguous proximal cap, right? So and then I got so that's kind of what I'm dealing with, and this is an Amplats, and I'm not sure I really have a anti-grid option here, right? So Dr. VT Shah is on, I think, or
Yeah.
Dr. Salvamani, Dr. Kasturi, anybody, I don't really care. So Dr. Rath, hi. So this is just something that hi Arun, hi Dr. Keshavamurthy. So yeah, we kind of decided to. I mean, do you want me to talk about it? Do you guys want to discuss? I don't know. I'll keep working as you guys are doing it.
So have you taken, Arun, first question is that if you had a CTO of RCA, you have revascularized the left system.
Right.
So would you like to wait for some more collaterals to develop, or you thought that there were sufficient collaterals and this was okay to take the next day?
It's really not for the collaterals. It was more for
the dye contrast and the radiation.
Yeah. So no, radiation is like, I mean, yesterday was 0.5 gray. We didn't use a whole lot. Renal function's normal. Today is, I'm pretty much done. I probably will do a few OCT runs so that you guys can discuss, but I'm less than 1 gray. It's 957 milligray. So both cases put together, it's less than 1.5 gray, which is, yeah, it's fine. So, so yeah, I mean, I don't think it was particularly unsafe, but now that being said, typically, right, in an ideal world, I would have probably just put it off for, 4 weeks or something, but welcome to India, welcome. I mean, and it's okay. I mean, we didn't exceed any safety threshold, so yeah. I'm pretty comfortable doing it today. So that's kind of where we are.
Do you think always we prefer IVs for CTOs? And your take on this thing, like OCT you have preferred for a CTO and in a live workshop, any points, any comments on that?
So, I mean, they're all different weapons, right? I mean, the different tools or whatever you want to call it. So this is not to say, one is better, one is worse, but typically if you look at it, like the big picture, right? IVIS is more utilitarian. That's what I told you. I've already, especially since I'm stenting Ostia, I was definitely going to use IVIS. So, and we did. We have an Intrasite 5 system. So, we can, I don't know if you can see the IVIS system, but so, yeah, we already used it. But on top of that, for stent optimization, I think OCT trumps IVUS, right? I mean, the high fidelity and the resolution with which you can see certain things. Now, there's a big myth that you can't use OCTs and CTOs. Not really. You can't use MLD max. I mean, I would say this is kind of a modification of that. You can still use it for the max part. You just can't use it for the MLD part because you don't want to inject until you have stented. So it's just remember, it's not one versus another. It's just that they are complementary imaging techniques that have different strengths and different weaknesses, and you got to do it as intended. So, good. Guys, ACT, check one. Oh. All right. So how would you approach it?
Yeah,
Dr.
regarding the
Raj,
approach with such an ambiguous cap, of course,
Yeah.
you always start with an antegrade approach, but you are ready for a retrograde because you
Yep.
see some good collaterals and
choice
from the
of guides,
septums. Yeah, yeah.
guide.
Implants
What
would
would
be
you
a good
choose?
choice for the right. Yeah, one.
We you know, we kind of interrogated really briefly, and in fact, even with the, I mean, I can tell you, so antegrade, we didn't make a whole lot of progress. I mean, I didn't try. I mean, I don't know when I started it, so it was probably like 8. Yeah, it's actually 9:17 is my setup shot time. So that's so I think I stuck around 9 o'clock or something. Whatever. So that's our initial setup shots. Get the guides in, get wires. I mean, I always put in a safety wire. So that's kind of where we are at now. I mean, not now, but like we were at, I guess, less than 2 hours ago. And then the next step really was, one of the things is I don't believe in wasting time. This cap was clearly ambiguous to me, and I'll kind of play it again. It's going to be a real pain in the rear end trying to, dude, just play it. Yeah, thanks. So I got great usable collaterals. It's not a particularly long CTO, so I was like, all right. So my plan was to go, I mean, I got in retrograde, had some difficulty. Interestingly, right? I had some difficulty tracking my balloon. Oh, hold on. Okay. But then I got a microcatheter across. I mean, the collateral itself, I don't know if this is the, yeah, I mean, I surf, not to surf, whatever. I mean, get the job done really is the point. Yeah, so I'll just, yeah, surfed a little bit, crossed it. So again, if you look at it, this didn't take too long. By 9:36, I was across. And then the challenge here is that I have a left main stent, right? So I don't want to go, I can't do my usual deep throating too much. So I got to be careful. And then the Corsair, and this is the thing with septals. These days we can cross a lot of the collaterals, but microcatheters have not really kept up. So this is the Corsair Pro, which is an improved version of Corsair, but we're still kind of struggling to cross. All right. So what I did was I pulled out the whole thing. I ballooned. I took a 1.5 mini track. I don't remember something region plus something. One of the 1.5 balloons, dilated the track, and then I made it kind of easy for the Corsair, and play it again. Yeah. So sometimes people have this misconception that crossing the collateral and then you're home. It's just one part of retrograde CTOs. So you really gotta it's not over until it's over. So what I did was I managed to get into the aorta there, but then the Corsair was really struggling. So I'm gonna stop at this point and let you guys discuss, because otherwise it's going to be a monologue. So
what is the wire? Which wire did you use to?
Yeah, it's a Pilot 200.
Pilot.
So yeah, now my Pilot 200 is in the aorta. RCA, that's what I'm dealing with. I got a retrograde, and this is a New York Corsair Pro 150, and it's struggling. So, panel, what would you do? So I'm gonna let you talk, and I'm just gonna do one quick IVUS while you guys are discussing. Is that all right? You can see it too.
Sure.
Okay. Yeah, you can. Yeah, I just want to be sure I covered the ostium, so I'm just gonna take a look, if that's okay, and I'm happy to get your input. I got a lot of imaging experts here, so guys, make the IVUS screen really big once we are in.
Yeah, but Arun, we would be interested to see that IVUS run where the wire is going out from.
I'm going to show you guys.
Lumen to lumen or subintimal.
You can see it.
Yeah.
In a second.
Yeah.
Let me show it to you. Yeah. Okay. Good.
Were you able to get into the guide with that retrograde wire?
what would you do? Here is the situation. No, it's an Amplatz. It's kind of anteriorly directed. Your Corsair is exactly, I don't know, 20 millimeters from the guide.
I think you have to change the wear here. For retrograde, you have taken a pilot. You need to have a stiff wear to cross it.
But you've already crossed it. So my point is,
no, but this is a better idea to image it where exactly you have crossed it and how it is going from there.
Really? So you guys would
and you already have a wire in the side branch there. It's no big deal.
Yeah. Okay. Sure. Make the IVUS the big one. So yeah, I mean, I think that's a great thought. You could definitely throw in an IVUS catheter since we already have it. So guys, this is you guys can see it now.
Yeah.
All right. So Abbott guys, I'm so sorry for showing IVUS, but again, different tools, guys. Okay. So guys, I want to just see where we are. Can I just, yeah, please.
This is a previous run, I believe.
No. This is live, man. You guys are seeing it right now.
Is there already a stent over there?
I'm done with the case. I'm just showing. I mean, I just finished.
Oh, sorry.
So, yeah. Sorry. So yeah. But I just thought because it was OCT, I was going to do an OCT run for you guys just to. But this is I just want to be sure I covered the ostium, guys. So I would love to get your input on that. So I'm just coming back. Okay. So there, see that? Okay. And in fact, as you can see, that's a JR4 guide I have now. I think we covered it, right? The ostium looks covered, right? That's the aorta.
It's not clearly seen.
You can go in again. You see, with IVUS, that's the advantage. You can go 10 times in and out at the ostium and be sure.
See, you guys see it? You see the stent struts now, right?
Yeah, we can see it struts now.
So I'm going to come back together. So just watch it.
Yeah.
Watch. Okay. And actually, I don't know either. I'm just, I would love your opinion. This is real time.
Sure.
Okay, I'm coming back slowly. Don't inject. Do not inject.
Yeah. So from 7 to 12, if you can see.
It's there.
Yeah, still.
Yeah, I can still see stent struts, man. So that's good. And I have a better resolution than you, so you kind of have to, I trump you. And that's the aorta.
Yeah. So
I think we're okay.
Okay, just about.
I think we're okay. I mean, the question is, do you want to put in another stent or not? Flip it, guys. Flip it. Okay, get back. Okay. So then I'll tell you what I did. All right?
Do you think the stent is a little bit underexpanded?
Underexpanded. Yeah.
For the ostium, it looks to be underexpanded.
Yeah, we are dilated with a 3.5 NC. I might have to go up higher. Okay, let's just get this disengaged. Okay.
So,
guys, I want hemodynamics on top, please. Okay, good. Okay, good. All right. So I'm gonna. So guys, he is not the most. I mean, he's moving around a little bit. So I'm gonna be a little bit quick in terms of what I show you guys now. I would also love to show you an OCT run of the left main. Enema, OCT check one. We'll just show them a quick OCT run of this, right? Guys, I'm gonna get antigrade wires on both, and then let's make the system antigrade before we move any further. All right. So can one of you guys talk about what it? No, I guess you can't. Okay, so hold on. All right. Okay, pressure is good. All right. So yeah, I mean, this is where I left you guys, right? So what I did was I just pulled out the fine cross. I tried to move it up. I pulled out the Corsair Pro, put in a fine cross, and that crossed like butter. And then the next thing I did was plate. Okay, guys, kaltu kadinga, plate. Okay. So I just wired. I was ready to snare it, but then I just managed to wire the guide. Did you guys see it?
Yeah.
That's a live fluoro. So okay. So I just try to save this stuff for you guys. Then I did a tip-in just to make the system antigrade. That's an antigrade Corsair. But interestingly, it still didn't cross. So then I just put in a RG3, externalized the system, ballooned it, stented it, IVUSed it, and now I'm going to make everything antigrade so that we, it's just going to be easier. Okay, I'm going to do OCT runs on both the left main, LAD, and this. So let's just give me a few minutes. If you want to switch over to Dr. Balbir.
Can we see the final NGO of right?
Sure. Yeah, guys can. Yeah. Guys, can you just show him that? Okay, but stand. Gonna play it now. Okay.
Arun,
Wait, Bana.
Dr.
Yeah.
Arun, we'll
Yeah.
go to Dr. Balbir Singh.
That's good.
Again,
Play,
we'll come back.
And come back.
Play.
Is
Yeah.
it okay?
Yeah, that's. You guys can see it.
Yeah.
Yeah.
Okay, and then we did a full run too of IVIS, so I'll take another picture with the OCT anyways. So good.
I will come back.
Then. Yep, sounds good, guys. Super.
Okay, Dr. Ravi, you can.
You can switch to the other lab.
You can switch. Ravi, are you there?
So switching.
Yeah. Okay.
Negative.
Dr. Balbir sir, we are with you.
Yeah, so we are, I'm just going to go through the steps, but I'm at the moment fixing the stent in the ostium and the left main. So just give me a minute. You can see the screen? Can you see my screen?
Yeah.
Yeah. You're able to
just
see.
Deployed the stent. 14. Down. Negative. Okay. So I am concerned whether the circumflex stays open or not. So I'll take a shot. Patient's having a lot of pain, so yes, it's still patent. It may go when I dilate. Okay, now I'll go back to the steps. Okay, negative. Okay, minus करो मुझे frames दिखाओ सारे. Minus. So we left you at the stage of having done the IVL minus. After the IVL, plus now. Plus after the IVL, I took a 3 millimeter cutting balloon and cut it across from the proximal part of the stent to the ostium of left main. Can you see the picture now? This is the angiogram after having used a cutting balloon. So looked reasonably good. And 3 millimeter cutting balloon from the ostium of LED left main proximal to the all along the distal part of the stent. Then we went for the OCT. I will show you the OCT pictures now.
Balbir sir, when you did your IVL,
yeah,
did you have any waste giving away? Did you see anything?
No,
like that?
I didn't. So when I did that, I realized probably I could have used a cutting balloon right from the beginning and would have worked. I didn't see any waste which gave away. So even at 4, I could see the balloon was reasonably expanded. So this is what it is. You can never predict what's going to happen until you do it. So this is the OCT run.
We can't see the OCT.
दिख नहीं रहा, OCT नहीं दिख रहा उनको.
Did you complete all the 80 cycles or you're still something left over?
The audio connection is lost, I think. Dr. Balbir?
I think.
Yeah, I think now it's back.
Do you see
Dr.
the OCT
Balbir?
images?
Yeah.
Yeah, can you see?
Hear us?
Yeah, I can hear you now.
Yeah,
Do you see the OCT images?
Now it's visible, but the
Dr. PC Rath, you can comment, sir. Are you there, sir?
I don't know. Isko.
Dr. Keshavmurthy, you can involve for Mohanty, PT Shah,
Yeah.
Dr. PC Rath, and one by one, you can put some leading questions and discussion. You can.
Dr. Sridhar, can you see the OCT image now?
no, it's
Yes,
not
sir.
running.
But not moving.
It's
playing.
not moving. Yeah, play it.
Okay,
and
it
we
will
can
move
discuss.
now. Yeah. Is it, you see the still frame, don't you?
Yeah, steel frames
now
are
it's
visible.
moving.
Okay, so I'm going to move it now. So this is the proximal part of the stent. Now you see the lumen area. This is after IVL and the cutting balloon is 4.6. look at this expansion. I will go back to the previous view and show you how different it was. So the idea to use IVL was probably this only, that I wanted to get a better expansion. You don't see calcium when the stent is there. It's very difficult for OCT to pick up calcium most of the times when there is a restenosis. So the stent was clearly underexpanded, and it's almost double at this point. I will go back to show you the previous frames also. So as I run the image, you would see that the lumen area is almost 75% more than what it was when we took the first run. And these see the dissection plane, see the cut of the IVL balloon. See the cut? That was a cut at the calcium level. I'll go back to that. This was the calcium at 6 o'clock. This is the wire artifact, but this is the cut. Is it clear?
Yeah, that is with just a 2.5 balloon.
Yeah. So as we go further down, we see the lumen area is now 3.4. It was 2.0 at that time. See the dissection plane. So one loves to see these dissections. So we measured the vessel size in the proximal part of the LED, which is 3.3. So this is the media here, and this is the media here. We don't see media here, so we calculated on the transverse angle, it was 3.3. So we knew that proximally the vessel is bigger, even though it appeared as 3, but now it is 3.3. And this is the lumen area near the ostium, 4, which is again 2.1. See the calcium fracture on the top, 12 o'clock. See the dissection. Now we are at the ostium. This is the left main, a lot of dissection in this area. And as we go back, we will visualize the normal portion of the left main. So if we measure it again, the left main, we see it's about 4. Media to media is 4.1, and in the other plane, if we look at the lumen to lumen, it's about 3.2. So I'm prepared to use a 4 millimeter balloon here. But I will go back to that stent again, because that's some learning thing here, that if we see the expansion of the stent here, 4.69, and I go back to the previous projection, it's 2.0 just distal, and here it's 2.7. So you see that the proximal part of the stent, as you see in the transverse view, this one, you see the tapering that happens here in this part. This tapering could also reflect a lot of neo-intimal, so you may not be very accurate. But clearly the lumen area was 2.7, and we achieved a lumen area 4 with an IVL. So that was a good idea to get into this part of the stent and to inflate the IVL at this. So I started IVL from here and all the way to the left main with a 2.5. Of course, 2.5 would not be adequate for left main, but the calcium was not too much in the left main. So main calcium was here, and there was underexpanded stent in the proximal part. So having measured that, we knew the diameter distally was around 2.3, and proximally was 3.3. So we chose 2 stents, 3.38, which we go to the angio now. So after this OCT run, I decided to dilate the proximal part of the LED with a 3.5 millimeter balloon. Next, please. Next. So I dilated with a 3.5 millimeter balloon, the distal LED, ostial LED, and the
left main.
And the left main. So next, after that, we chose our first stent, which was a 3x38 Zions expedition, and overlapped it to the proximally with a 3.2533 going from LED to the left main. So all this was measured on OCT and the sizes calculated. So next, please. So this is the first stent.
So did the OCT help you to decide the distal landing zone? Did you overlap the previous stent completely or partially?
Dr. Balbir?
Yes.
Any preference for giants? Any platelet ideas in the mind, or you want a short DAPT or something? You prefer a stent over other?
So, okay, so there are 2 studies. One is Onyx 1 study, which had 1 month DAPT, and the other was a stop DAPT with the Zyme stent. So Onyx one, they compared 1 month versus prolonged DAPT and found equal result. In the stop DAPT, they found between 1 and 3 months of stopping dual antiplatelet with Zymes, very similar results. So very limited choice. Whenever there is an osteal involvement, I want a more rigid stent, so that's why I chose Zymes. It could have been anything.
Freedom.
And secondly, Giants 28, Giants 90 also studies have shown short DAPT of 28 days.
So the proximal stent chosen was a 3.2533. Yes, there was a question whether I used the landing zones on the OCT. Yes, I did. I chose the proximal landing zone, and the ostium of left main was my target for the proximal stent. Next. So this is the second stent, which in three different views, we covered up to the ostium of the left main. Next. And made sure that we are covering the distal stent also. So we just had a couple of millimeters of distal stent, and this is the iliocranial showing ostium of the stent is covered. This is where we deployed the stent. This is 3.2533. Next. Having deployed that, next. I have not done any post dilatations. The circumflex flow was still maintained. I still think that after 4, it may just reduce, and I could be in trouble with recrossing this circumflex and ballooning this, because I want to save this branch. Next. So this is where we are, and I will show you the caudal projection now. And we then start optimizing the stent. So my plan is 3 millimeter, 3.5, and 4 millimeter balloons all along this plane.
This this proximal part of the left main, I think you should optimize it with a bigger balloon. I think it is not well expanded.
Absolutely correct. The left main size we already calculated was 4.2, and we have chosen a 3.25 stent. So my next target is to do a pot with a 4 millimeter, with a 4 millimeter balloon.
That way it will be easier for you to go to the circumflex again and dilate it.
Right, absolutely correct. 4 millimeter.
Why not a 4 millimeter stent right away? Because you had a distal overlapping stent.
Our stent is already there.
The ostial LED is already 4 measured on the OCT.
No, ostial LED was 3.3, media to media.
Right.
So 4 millimeter could have been quite
Oversized.
big for the, and it would have made sure that I lose the circumflex. And
So what is your strategy for circumflex?
I just want to save it. I don't want to do anything. It's a long lesion. You can see that. The branch is so small that I don't want to get into trouble putting a long stent in the circumflex, have a bifurcation to the left main, knowing that he has a high bleeding risk. That will be a disaster to do that.
Drug-eluting balloon?
Yeah, maybe if things don't go well. Let's see.
But your OM graft is working also, isn't it?
No, it
On
is
the
not.
OM.
Chalo.
One of the grafts was working, I think.
On the OM, some graft. Oh, RCA graft is working.
14, 18. Down. ये stitches हटा दो. Elio call. Okay. 14. Down. Circ is still flowing. $20, $22, $24, down. $24, down. 3 का balloon देना. 3 है हमारे पास नहीं है 2 3 का balloon 3
Now we want to recross into circumflex or later?
Yeah, I would let's see how the flow is, and I make pre-cross now. Yeah, I will recross. Wire needle talk. But at least it's flowing, so it makes me not so uncomfortable. Yeah, and we have a big RCA, so that takes care of most of the circulation. So we have a large PD and a very big PLV. Test.
And right now he has no chest pain and no STT changes at least.
No, not at all. He's very stable now, very stable. He's crying in pain when I was doing it, particularly the IVL.
Dr. Vitisha, you can tell your strategy.
Yep.
I think it's fairly reasonable that because of his high bleeding risk status, we do not want any bifurcation stenting and take that risk. If the artery is flowing, there is no chest pain, no STT changes, fair enough to leave it. If at all, maybe do some POBA with 1.5 millimeter at the ostium. If that short segment,
I would
look. If that looks very critical, I don't know now. Maybe after NTG or nitro or something, you can still
20.
Dr. Balbir, for a large circumflex, do you usually do a kissing balloon to optimize the stent studs?
Yes, I do. I never used to do it, but then I saw some OCT images of my own patients where, they had very ugly looking endothelium on the mouth of circumflex.
So it's a routine practice for you?
Now it is a routine. 20. With a smaller size balloon on the circumflex. 22. Just to open the struts towards the circumflex.
Exactly.
Down. 28.
But we don't have a recommendation for that.
Yes, I know.
For from EBC or any other
no recommendation.
No recommendation for that.
Yeah, retrospectively, it makes you wiser because when you have to recross for some reason into the circumflex, especially in the left main bifurcation, you're better off having pre-dilated in the first sitting.
See, there is no recommendation, but there is acceptance of the fact that
28.
if you leave a strut on the ostium or a link on the ostium, it is a cause for worry. They have established, in fact, in that EBC document, there is a photograph of a positive picture on that, where the link and the strut
28.
on the ostium is there.
Down.
So they have shown concerns. Its only question is
28.
whether routine will make a difference.
Down.
And see, trials and studies are studies and trials. They look at statistical significance. In a single patient, we cannot look at statistical significance.
The argument against using routinely kissing balloon is you probably will be injuring the ostium of the circumflex, thereby increasing the chance of restenosis.
Yeah.
You routinely do all the cases.
Yeah, that's true.
No, the point against doing a kissing balloon is the Excel trial where kissing balloon inflations did not prove to be useful. In fact, the outcome was slightly worse. And the reason behind that is that the kissing which we do is with long shoulders overlapping in the left main, thereby deforming the stent. That is what the hypothesis is. So if you do with short balloons, very little, just like something like snuggle, then it would not create any deformity. That's the hypothesis.
So,
but undersized balloon, definitely what Balbir said is right. We also do the same thing nowadays. Just undersized, get the strut out of the opening. So Balbir, what's your take now? Still it's flowing good?
Yeah, very well. So I don't want to get with the 1.5 billion because
Yeah.
I don't want to deform the stent in any form, because that is the most crucial. The circumflex is not going to impact him at all. So we go to the OCT now. Can you show the OCT images? Okay. Start. Okay, so this is the OCT run. So we will carefully look at the stent expansion and other things. So the proximal part is very well done. You can see the proximal LED ostium left main seems to be good. We'll just measure it, but looks good in the first run that it looks like. I'm going to analyze it for you. So this is the left main part. You see the bifurcation here. This is the circumflex coming out. This is the left main. So the MLA is more than 10, 11. So it's reasonably good. Even at the ostium of LED, this is the ostium of LED. It's about 6.75. This is the lumen area. Now this is a software which tells us that it's 68%. But what it does actually is little confusing, because it has taken into consideration this left main. If I take the ostium here, the lumen area is about 6.6 to 6.7, maximum 7. So if I take the lumen area here, it is 6.2. So clearly it is not 70%, it is much more than that. So this is some policy of this automated algorithm. So if you look at this part of the vessel, there's a plaque there. This is the previous stent. Now we come to our stent today. It starts here. So this is the overlap portion, and then it starts here all the way down. We will go ahead and dilate this portion, maybe 3 millimeters. So I'm going to dilate this part again. It becomes 4.9 here, 4.4, 4. And when you get the branch, then it suddenly becomes much bigger. This is the part where there was maximum calcium, and it's 8.4. This was the tightest portion. So this also was the tight disease there. So in this part, it has expanded well. I'm a little unhappy with this distal portion, which we are going to dilate with a 2.5 millimeter balloon for sure. Go at high pressures in this part of the stent. And maybe if you look at the proximal part, it's 6.4, 6.6. And if you look at the circumflex in the bifurcation view, let's go and see the circumflex. So this is the mouth of circumflex. You can see the wire. So it helps you to decide. This wire has gone through the proximal portion. It is behind the link. You see this wire going behind into the circumflex. I'll rotate it for you. Let's go rotate. See the wire? Now, if I have to do a kissing here, it's going to be difficult. I would like this wire to go distally through this part, avoid this link, and then go through this. This wire position will make, if I want to do a kissing, my kissing balloon will be difficult to cross first. But if it crosses, you'll still have this link hanging. So this is what Dr. V.T. Shah was saying about the link hanging in the circumflex mouth. So this is the link hanging. And when restenosis happens, because this becomes endothelized, that part of the ostium circumflex suffers. So this is what it is, but in this patient, I'm not planning to do any such thing, but just to demonstrate what it means for the proximal and distal wire crossing, and clearly showing you where it is. So I know where I have to redilate. This is the portion which I have to dilate. This is 4.2. This is the portion which I have to dilate, which is 2.6. So it's a small vessel there. So it's a 2.5 balloon there. It will optimize my result even further. Any comments now?
I think it's a very nicely done case, sir. Excellent case. Very high in the subset of high bleeding risk. Avoiding the second stent is a very intelligent strategy. It's because of getting good flow from the right coronary and LAD, very huge. And the second stent definitely is going to increase the MACE rate, and you maintain the flow, and the LAD and left main optimized very well. And because if you are putting two stents, sometimes you may have to extend the DAPT compared to single stent strategy, because patient comes under high risk status. Even here, if you restrict for 1 month also, that would be enough to reduce the bleeding complications. But a very beautiful demonstration, even OCT image also, expansion, opposition, very well shown, and even LCX flow is maintained. I think even LCX is not having many branches. I think very, very strategically, I think beautifully done from my side, from the bottom of the heart, showing such a nice complex case. Thank you very much. And Dr. Vitisha and Dr. Keshav Murthy and Mohanty, you can say a final few words, then we'll move on to.
No, I fully agree. It's a nice demonstration of OCT guided complex diffuse disease, a crossover technique, and when to stent, when not to stent. With the basic goal of a procedure is to minimize the metal load to the artery, and nicely demonstrated the side branch wire crossing. And if at all you want to put a second stent, you go distally and other things. Yeah.
Dr. Vitisha?
22, 24, down.
Sir, unmute.
24, 28.
Sir, unmute. Dr. Vitisha, unmute, sir.
Down. 24.
Dr. Shah, you're muted.
Down.
Yeah, sorry. So, congrats to Balbir for showing such a excellent case, high risk subset, complex case, and with excellent strategies as to how to deal such kind of lesions and such kind of subset. So, thanks and congrats for the same.
Thank you, Dr. Vitisha. Thanks, Sridhar, for opportunity to show a case here, and thank you everybody on the panel.
Yeah, and thanks to all the staff for coming on Sunday and showing us this case.
Three.
Yeah,
Dr. Selvamani, you want to say something? Dr. Selvamani?
Yeah, sir, as usual, excellent demonstration of OCT and then strategy, especially in a patient with high bleeding risk. We learned a lot, and a great demonstration of imaging tool. Very nice, sir. Congratulations.
Thank you, Dr. Selvamani. Thank you very much.
Thank you, Dr. Balbir and team, and thanks to Dr. Sridhar Kasturi for organizing this wonderful session.
You just,
we'll go to the other session. Yeah. We'll switch to the other lab and see the result there.
Ravi, just go to, Arun. Arun, we are with you. Dr. Arun, are you able to hear?
20. 28.
Okay. Connect to the pressure here, please. Okay.
Yeah, Arun, we are with you.
Have to go off. Okay.
Dr. Arun, you are live. Yeah.
We can't go live right now, guys. Sorry. Okay, I got it
down.
Oh, okay. Okay.
Okay. Meanwhile, we will have a discussion. Dr. Vitisha, you can raise some points, and Keshav Murthy, you can lead the discussion. Dr. Selvamani is there. Mohanty is there.
Yeah, regarding the retrograde approach.
Dr. P.C. Rath sir is also there.
Yeah. Dr. P.C. Rath and Dr. Shah, can you give us some tips on how to protect the left main in a retrograde approach? Because dissections, and once you have crossed and trying to snare and trying to bring multiple devices, what are your strategies or tips to protect the left main?
As a donor vessel, you are saying?
As a donor vessel.
Yeah. So I was thinking of using the guideliner actually, just an
Right.
extension catheter instead of hitting that guide catheter every time on the stent. But
Yeah.
I mean, an excellent operator like Arun, we don't have to say all these things. He must have taken all the due care for the same. But nevertheless, Arun, I can see one point of dye staining there. If you can just, was the wire there somewhere, or was it the retrograde wire? What was it?
I think they have not connected.
Yeah.
It's not live.
Probably he doesn't want to be
Dr.
live.
Bishira,
So.
sir, unmute.
Actually, I don't know. I had during retrograde, I had a dissection of the left main once. So most important thing is the microcatheter don't take out till the procedure is over. So always protect the left main with microcatheter. In this case, he already has a stent in left main. So in a way, it is little protected and all that. Putting a guideliner.
No, that is because to avoid proximal distortion of the stent.
Stent
Like
distortion.
a guide catheter, every time he goes in and out.
Putting the guideliner is a good idea to protect the stent. But you know this without stent, the chance of dissection is there. With stent, chance of distortion is there.
Distortion is
You have
there.
to keep it in mind. Balance of the retrograde wear and between two operators is most important in this case in retrograde technique, because there should be real good harmony between these two.
Yeah, good coordination has to be there between the two operators. You are right. Especially while pulling the gear, the other guide catheter will get sucked in.
Yeah.
These are all important practical guidelines for retrograde.
And when do you remove the retrograde wire?
No, but you
Just
see,
before stenting, or do you jail the retrograde wire sometimes?
no, see, in his case, he has externalized the wire. Once you have externalized the wire, on that same wire, you can finish the ballooning and stenting.
Right.
Okay. And then put an antigrade wire and you can do imaging also and all that. But most important is that the withdrawal of the retrograde gear from the donor vessel has to be the last thing. Don't be in a hurry to remove that retrograde corsair or microcatheter and the wire before you have stented your main vessel CTO. Because what will happen is, if you see some perforation leak somewhere which was sealed because of your gear and now suddenly it has opened up.
Yeah.
Then before you have stented the donor vessel, you will be in a mess. Finish everything. That should be the last thing. So that you can take care of whatever perforation or septal hematoma or whatever is there or dissection, you can take care of it. And by that time the donor vessel is ready even to give collateral flow to the other vessels in case there is a close down.
Absolutely important points. These are all things, means in the early few cases of retrograde, you face such complications.
Correct.
Donor vessel dissection, left main dissections, perforations which you don't notice and take out the
And
donor vessel
especially you
catheters.
see in his case, he pre-dilated the collateral, septal collateral with 1.5 millimeter balloon.
Yeah.
Now, when we do that, we have a wire there in place and then we put a microcatheter through that. So whatever is the leak doesn't happen at that time.
That time.
It's only when you remove it, you will have it. So we are very careful at that point. Remove first the microcatheter, just withdraw it to that point, see whether there is a leak there, and only finally, otherwise, if you remove the wire also, you will lose access and you can't put in coils there later on.
Yeah. Do you routinely dilate, pre-dilate those collateral channels? I never dilate the collateral channels.
Not routinely, but if we have to, nowadays we do it freely rather than earlier. See, now we have 0.85 balloon also.
0.85, yeah.
So that is sufficient for a microcatheter to push in. So
Right.
we don't have to go to 1.5 also.
Yeah.